Good morning, everyone. My name is Tahara Bhate, for those of you who don't know me, and I'm one of the EM residents in Calgary. My grand rounds today is a toxicology talk focused on ibogaine and kratom. I'd like to thank Doctors McGillis and Rose for the inspiration and assistance in preparing this talk. And of course, I have no disclosures to make. So to begin with, why this topic? Opioid addiction with its associated morbidity and mortality is a familiar presentation for emergency physicians, and few of us are likely to be surprised by Health Canada reports of over 9,000 opioid-related deaths between 2016 and 2019, with 11 lives lost each day. Our treatment options depend primarily on pharmacological substitution, which unfortunately is not always effective. Because of this, there are a variety of herbal supplements marketed as alternatives to help with opioid addiction. Anecdotal reports suggest use of these supplements is increasing, and while literature searches will reveal an extensive list of these herbs, particularly from Chinese traditional medicines, there are no rigorous scientific evidence to support their usage, with patients accessing them independent of mainstream medicine. However, as unregulated herbal preparations, their effects and potential toxicities are not always well known. Our objectives today are to provide a broad overview of ibogaine and kratom, including their pharmacology, clinical presentation, and management. These were chosen because we've seen examples of these in our Calgary EDs, and we're likely to see more. In terms of local context, stats from PAVIS show that there were 4 and 17 calls for ibogaine and kratom between 2017 and 2020 respectively. And while those may seem like small numbers, American trends suggest that kratom is a drug we should be familiar with over 1,200 calls to US poison centers between 2015 and 2017, and an estimated 5 million users in the US. Ibogaine is much harder to track, but is accessed through non-regulated detox and recovery clinics, including this one, the Anuksha Counseling Service, which is here in Calgary. So to begin with, let's talk about a case. This case is a 40-year-old female who presented to the emergency department 4 hours after ibogaine treatment in a local clinic. She became unresponsive, but was revived by Narcan in the clinic. In the ED, she presented as slightly drowsy with largely unremarkable lab work. Her ECG, however, showed significant QT prolongation, with a QTC of 611 compared to a previous ECG showing 408. She was admitted to a monitored bed and received treatment with IV magnesium and serial ECGs. This ECG was taken almost 12 hours later with a QTC still of 581. Her ECG did not normalize until about 24 hours post-ingestion, and at that time she was able to be safely discharged home. So ibogaine. It's a naturally occurring indole alkaloid, which is isolated from a shrub, shown here, called Tabernanthe iboga. This plant is a rainforest shrub that is indigenous to West Central Africa, in particular Gabon, just west of the Republic of Congo. The use of ibogaine actually dates back thousands of years in Africa. It was first used in rituals by Pygmy tribes of the region, and it was incorporated into an indigenous religion called Bhate that began in the early 20th century as a response to French colonialism, as the indigenous population moved into the rainforest and mixed with the Pygmy tribes that still lived there. Bhate has grown and matured over the 20th century and is now one of the 3 official religions of Gabon, with modern-day practitioners seen here, with practitioners now outside the country. Bhate is predicated on a ritualistic connection with the ancestors, which is facilitated by the hallucinogenic and dissociative state brought on by consuming large quantities of iboga, which you can see they're doing here on the left. In contemporary history, ibogaine has a storied past. It was first identified during the 1960s by a group of laypeople led by Howard Lotsof, who were conducting semi-structured experiments with psychedelics. They found that ibogaine improved feelings of withdrawal in the heroin users in the group, which were about half of them. One reference I found actually termed this drug discovery through recreation. Lotsof attempted to develop ibogaine into a treatment, but its unorthodox origins and the perceived lack of profit in addictions treatment hampered his efforts for the next 20 years. He eventually was able to start a phase 1 trial with the FDA, but it was stopped early with conflicting information as to whether or not it was due to side effects, funding lapses, or politics. On a side note, the story of ibogaine is fascinating from a drug discovery and policy lens, and while I can't go into a lot of detail about that today, there are some references in my slides if anyone is interested in that side of the journey. Currently, ibogaine is a Schedule I drug in the US, and it is controlled in Canada, meaning it should require a prescription. However, there's significant unregulated use in private detox centers around the world. The largest and most well-known of these are in St. Kitts and Cancun, but they exist in almost every major Canadian city, including here in Calgary. The larger centers have MDs associated with them, and they've been able to publish several small open-label observational studies, which show a positive effect of ibogaine on opioid withdrawal symptoms and long-term opioid use. But it's worth noting that these centers are often funded by advocacy groups who push for the mainstream medicalization of psychedelics. As well, given the importance in both these studies and online communities of the personal journey of discovery that is reported with ibogaine treatment, it's difficult to tease apart any chemical effects of this drug. Finally, as a bonus, does anyone know who this is? And actually, I shot myself in the foot because I can't see any responses, so I'll just tell you. This is a picture of Hunter S. Thompson, who's a famous US journalist. And he once suggested that a candidate in the Democratic primary in the 1972 presidential election, Ed Muskie, was taking ibogaine. It was a complete fabrication, as he admitted at the time, and it was perhaps the original fake news. However, it had such an impact that it was thought at least partially responsible for the overall outcome in that election. So in terms of its pharmacology, ibogaine demonstrates complex interactions with multiple neurotransmitter systems, including NMDA antagonism, opioid agonism, and serotonin and cholinesterase inhibition. The mechanism of action remains poorly understood. In addition to the neurotransmitter effects, upregulation of proteins has been reported, including one called GDNF. This has actually been shown to restore damaged dopaminergic neurons, theoretically resetting the dopaminergic pathways to a pre-addiction state. Finally, as highlighted, the psychological effects of an ibogaine quote-unquote trip are also potentially important, with patients reporting emotionally intense, sometimes frightening visions, such as scenes from childhood or past mistakes replayed and somehow released. Ibogaine is rapidly metabolized by the liver to noribogaine, a biologically active metabolite with a similar receptor profile, and a prolonged effect due to some enterohepatic recirculation. While both substances are highly lipophilic, the much longer half-life of noribogaine is theorized to be responsible for the persistent improvement of withdrawal symptoms that is often seen at more than 1 month after ibogaine treatment, as well as some of the adverse toxicological effects. While there are numerous first-person reports of ibogaine intoxication, especially in online communities, there's only one observational study in the literature. This was published by Dr. Mash, who's a primary driver behind medicalizing ibogaine and actually holds patents on ibogaine and many of its derivatives. The study was published with patients from her own treatment center in St. Kitts, which I referenced before. In her open label series of 191 patients, minimal side effects were reported and are listed here. Hypotension and bradycardia were the most prominent at about 5% and were readily treated with IV fluids. There were no changes seen in biochemical parameters, including LFTs, and while they don't specifically state their telemetry results, presumably their lack of findings indicate no adverse changes. The doses they used were about 8 to 12 milligrams per kilogram, which is what is recommended by the Global Ibogaine Alliance, a very active advocacy group. In terms of toxic effects, cardiotoxicity is the most well-known risk and was highlighted in our initial case presentation. The mechanism is unknown, but the bradycardia is thought to be secondary to cholinesterase inhibition, with QTc prolongation secondary to potassium channel blockade, which incidentally was demonstrated in vitro along with sodium and calcium channel binding in cardiac myocytes. Cardiotoxicity is most commonly reported with doses greater than 2 grams, which is compared to the treatment doses of less than 800 milligrams that was used by MASH in her study. However, potassium channel binding in particular has been demonstrated in animal models at therapeutic doses. Ibogaine is considered more cardiotoxic than noribogaine, and cardiac symptoms should be seen by 12 hours. However, they may persist for greater than 24 hours, with the long duration due in part to the activity of noribogaine. Bradycardia often presents early, with QTc prolongation being the more persistent symptom. There are numerous case reports in the literature of cardiac arrest secondary to ibogaine, most often presumed secondary to torsades, in addition to non-torsades VF and VT reported. While some patients had pre-existing cardiac pathology, many of them had no known prior cardiovascular disease. Neurotoxicity is also common, with animal models showing direct neurotoxicity to Purkinje cells in the cerebellum. The same effects haven't been seen in humans, but cerebellar involvement is common, with ataxia and tremors common side effects. Seizures have been reported in larger doses, presumed secondary to cholinesterase inhibition. There are a few case reports demonstrating long-term neurological sequelae, including permanent cognitive deficits and visual loss, but these were thought secondary to hypoxia in severe cases that caused respiratory depression. Finally, there are a few reports of persistent psychiatric symptoms, including mania, delusions, and hallucinations for days to weeks post-ibogaine use. This slide is a summary of the serious toxicities that are found in case reports in the literature, both cardiac and neurological, and I included it because there are 2 points I want to highlight. First of which is that these doses seen here, they are high, much higher than would be used in a treatment dose in many of the detox centers. Secondly, the onset to these symptoms is fairly rapid compared to, if we compare back to here, the much longer duration in terms of time to onset for things like QTc prolongation. In terms of treatment, unfortunately, there's not much we do. Most acute intoxications require only conservative management. Cardiac monitoring should be done for any QTc prolongation until normalization, but usually a minimum of 24 hours. Patients who are asymptomatic should generally be monitored for at least 12 hours, but given the rarity of these presentations, I would certainly call PADIS and ask for advice with specific case presentations. With evidence of cardiotoxicity, consider your standard treatments for prolonged QT, magnesium, potassium, calcium. There's no consensus in the literature on managing ibogaine-induced VT and VF, but standard protocols were used in the case reports. There is no known antidote available, but naloxone has shown efficacy in ibogaine overdose when the patients appear opioid toxic. I also want to note that there are very few reports of ibogaine abuse in literature, so there are no withdrawal syndromes that have been described so far. Okay, let's switch gears to the second part of our talk today. A case presentation of a 25-year-old male who presented to the emergency department after a witnessed tonic-clonic seizure. On presentation, he was initially post-ictal, but rapidly cleared in the ED with a normal seizure workup, including CT head. His ECG showed a normal sinus rhythm with a mild interventricular conduction delay and a QRS of 148. For comparison, this was his routine ECG 3 months prior with a QRS of 117. Upon further questioning, he admitted to chronic kratom use and had just recently, prior to his seizure, taken more than 10 times his normal dose, which for him was 100 grams of kratom. Bhate was consulted and advised empiric bicarb for the widened QRS, but I wanted to highlight that wide QRS, while theoretically possible, is rare for kratom and should prompt a search for other co-ingestants. While that point might be confusing, I included this case specifically because of the rapid onset to seizure after his dose of kratom. This patient was discharged home 6 hours later with a normalized QRS, and follow-up documents in Netcare indicate no long-standing sequelae from his kratom overdose. Okay, so kratom is a preparation of leaves from the kratom plant, which is seen here, and is part of the coffee tree family and a native to Southeast Asia. Preparations include chewing the leaves, smoking them, steeping them as a tea, or compounding them into pill form. In traditional medicine, it has roles both as a mild stimulant, traditionally taken by day laborers, and as a sedative and pain reliever, taken as a nighttime tea. In Asia, it's generally not considered a drug of abuse, although it does have that potential, and it was recently legalized as a medical treatment in Thailand, where its use originated. Contemporary usage in North America can best be described as analogous to marijuana pre-legalization, where it's used for a variety of medical conditions as well as for recreation. It is considered by many users, perhaps erroneously, to be a safe, somewhat legal high. It is also found use as an alternative to opioids in chronic addiction. The legal status of kratom varies by country, and in the US, even state by state. In Canada, it's considered a natural health product, but is not authorized for human consumption. However, most sellers get around this by marketing it as not for consumption, and you will see actually on the pill packets or the tea leaves, it will be stamped not for consumption. However, it's not illegal to possess in Canada, whereas it is illegal in most European countries. Despite the legal gray status of kratom, it has become increasingly available, and usage is increasing, as I highlighted at the beginning of the talk. Many of these users are turning to kratom as an alternative to prescription opioids, which has actually led to significant advocacy from the addictions community and was successfully able to prevent the FDA from classifying kratom as a Schedule I drug in 2016. A quick web search revealed how easy it is to access these substances online. And on a side note, that is far from my only suspicious search that I conducted while putting together this presentation. In terms of its pharmacology, kratom contains a variety of compounds, with more than 40 psychoactive alkaloids identified. 4 are independently pharmacologically active, with mitragynine, unique to kratom, accounting for 66% of the alkaloid content. Mitragynine and its metabolite are the most well-studied, and both demonstrate significant activity within the opioid system, specifically the mu, delta, and kappa opioid receptors. They show mixed agonism and antagonism, as well as atypical activity outside the normal receptor pathway, and are an active area of in vitro research for potential pharmaceutical targets. Other potentially involved neurotransmitters include serotonin and alpha adrenergic agonism, as well as anti-inflammatory effects. In addition, these receptor effects can change significantly based on the dosing of kratom. That, plus the heterogeneous composition of kratom, where less active alkaloids may act synergistically, is thought to account for different clinical effects seen at different doses. Low doses generally produce a mild stimulant effect and are used as a performance and cognitive aid. Higher doses produce more of an opioid presentation, although reportedly not as potent as traditional opioids like morphine. Effects are documented to last approximately 6 hours, although mitragynine is known to have a half-life of at least 23 hours. Traditional side effects like constipation and meiosis have been reported, but there is debate about the prevalence of respiratory depression. It is definitely seen clinically, although in vitro studies suggest that it should not, based on receptor activity. Kratom is also commonly used as an antitussive in Asia, with similar efficacy to codeine. Its metabolism is primarily hepatic via the CYP system. In vitro studies suggest that the active compound is actually 7-hydroxymetragenine, a stronger nociceptive agent, which is metabolized from metragenine much like morphine is metabolized from codeine. In terms of toxic effects, there are 3 general patterns we'll discuss. The first is chronic usage. There are widely different reports of how long it takes to develop tolerance and dependency, anywhere from a week to 3 months. The symptoms are unusual and include a form of melasma seen here. I should note this picture is actually taken from social media, as I was not able to find any photos in the scientific literature. But there are significant online communities both in Reddit and on Facebook about warnings for chronic usage of kratom. Psychosis and weight loss are also prominent, but the mechanism is not fully understood. Chronic kratom use is associated with clinically significant liver toxicity, even failure, with over 50 cases reported, usually 1 to 8 weeks post-initiation of usage and in a cholestatic pattern. There have also been reports both in Thailand and in North America of neonatal abstinence syndrome in mothers who regularly drink kratom tea. There's also 1 case report of a patient presenting with severe hypothyroidism, including myxedema. Unsurprisingly, withdrawal tends to present similarly to opioid withdrawal, with symptoms starting within 6 to 12 hours of the last dose. Anecdotally, these withdrawals may be even worse than opioid withdrawal. Clinical data from the main poison center in Thailand over 5 years demonstrated the most common withdrawal symptoms were myalgias, insomnia, fatigue, and chest discomfort, with symptoms generally resolving in 1 to 3 days. Management is usually conservative, with case reports showing good effect from opioid-specific treatments, such as Suboxone or high-dose clonidine. For patients with chronic kratom addiction, there may actually be a role for long-term pharmacological replacement therapy, methadone, Suboxone, etc. There are case reports of using these drugs to treat either opioid-naive patients who have kratom dependence, or the more common group of patients who started kratom as a means to manage their opioid addiction, were unsuccessful with that, and now have dual drug addictions that they are managing with synergistic and worsening withdrawal symptoms. Kratom toxicity is most commonly reported at 15 grams or higher, with dose-dependent toxic effects seen at levels greater than 8 grams. Kratom overdose represents a particular challenge, as there are a variety of clinical presentations described in the literature. Stimulant effects are reported at lower toxic doses, with opioid toxidromes, including respiratory depression, predominating at higher doses. This mixed presentation was highlighted by a national US review, which showed agitation and tachycardia as the most common symptoms, with drowsiness and confusion the next most common, with percentages as shown here. This study also found a 6% incident of seizure, which is a common presentation in case reports, and it's often reported within 30 minutes of ingestion, as was seen with our case, which has led to the suggestion that kratom may actually be a proconvulsant. There is also 1 case report in a patient on quetiapine and fluoxetine of PRESS. Other than liver toxicity, which I highlighted with chronic usage, reported toxic effects in acute overdose are rare, with just 1 each of hypothyroidism and acute cardiomyopathy in a young, otherwise healthy patient. However, the US Poison Center data shows 152 kratom-associated fatalities over just 18 months between July 2016 and December 2017, with 91 cases thought to be due primarily to kratom. Most fatalities have been young males with a history of polysubstance abuse and co-ingestion suspected in 87% of the cases. However, data from Colorado, with 15 kratom-associated fatalities over the last 20 years, had 4 of them attributable to kratom alone. Cause of death across all series was mostly attributed to pulmonary congestion and/or edema. And unfortunately, when looking at these case series, there is no patterns we can draw, much like from ibogaine, in terms of what exactly it is about kratom that are causing these fatalities. However, we do know that most of the fatalities tend to present in a similar pattern to opioid toxidromes. Drug interactions with CNS depressants and stimulants are common, as well as interactions through the CYP system, either through competitive metabolism or even suspected inhibition of the CYP260 isozyme, which is seen with in vitro studies. However, there is a case report suggesting that this is a true clinical effect, with toxic levels of quetiapine developing with kratom co-ingestion. Finally, as an unregulated product, there have been warnings about kratom containing nickel or lead, and there was one recall report issued a few years ago for salmonella-contaminated products, which resulted in 75 hospitalizations and 199 cases across the US. Treatment is generally supportive based on presentation, and naloxone has mixed efficacy in the literature, but clinical experience from PATIS suggests that it should be given routinely. I should note there is one case report showing a benefit with intralipid. A 26-year-old male with no prior medical history presented in PEA arrest. His only past history was ingestion of an unknown quantity of kratom 24 hours earlier. ROSC was achieved with bicarbon naloxone, with intralipid added for high vasopressor requirements. His epi and norepi requirements came down by about 30% with ventilatory parameters, but unfortunately CT head showed herniation and decision was made to withdraw care. It should be noted that based on our local expertise in PATIS, intralipid is not recommended for kratom use, or kratom overdose, I should say. I mention it in case you're looking at some of the literature yourself and you see reports of intralipid, because it has permeated some of the literature reviews based on that one case report. As a summary, this is all of the potential reported toxicities with kratom and includes both chronic and acute toxic effects. The reference is at the bottom as it's from an excellent review that was just published this year. And it's worth noting that if you do a literature search on kratom, the number of studies and reviews published has increased exponentially over the last 2 to 3 years, indicating the increased prevalence of these drugs. So in summary, ibogaine and kratom are unregulated herbal supplements that are widely available and have increasing usage. Ibogaine is used for opioid withdrawal and has primarily cardiotoxic effects with QTc prolongation and risks of VTAC, VF, and torsades. There's no treatment other than standard cardiac support. Kratom is used similar to marijuana for chronic conditions like pain and anxiety, as a stimulant in low doses, and as a legal high in larger doses, legal being in quotations. Dependence is common among chronic users with an unusual constellation of symptoms, and withdrawal presents similar to opioid withdrawal. Acute intoxication presents either as a stimulant or more commonly as an opioid-like presentation, with the most common cause of death being an opioid toxidrome. Intoxication carries a high risk of liver toxicity and may respond to naloxone. I'd like to thank you all for listening this morning, and we'll turn the floor over for questions. I do also have Dr. McGillis with me to share his expertise, as he saw a significant amount of kratom presentations in the US. Dr. McGillis, did you have anything to add?
Hello, everyone. Can you hear me, Tahara? Great. Yeah, so in general, I don't really have too much to add. That was a great presentation. Thanks for that. So when I'm just talking about kratom a little bit, just to kind of simplify it for everyone's minds that might be in the audience, it's in general, it's just basically an opioid. So it hits the opioid receptors, the mu and the delta receptors mostly. And so the presentations that I've seen most regularly were either someone that was just coming in opioid withdrawal, or someone coming in an opioid overdose. So we had a huge Hmong population. So these are a smaller subset of people that were from Thailand. So a lot of people would use this just daily, therapeutically, make some tea. But I had an elderly gentleman that just boiled a couple of leaves that were a little too potent, and he ended up ending up with a total severe opioid toxidrome that was successfully reversed with naloxone. And then there was a lot of younger people that would come in. They were trying to, there's not a lot of addiction services available in Minneapolis. So people would try to treat their addictions on their own, by ordering these types of things online. And so I'd see a significant number of people come in, not knowing how much to take, and be in pretty significant withdrawal and be wondering why it's not working very well. So those are the two kind of main things with kratom. I haven't seen very much ibogaine in clinical practice, other than I was involved in the case recently with the long QT, and I had a few cases, but definitely the long QT and the potassium channel blockade are the main things that we worry about in those overdoses.
Awesome. Thanks, Dr. McGillis. Dr. Fedwick had one question asking how many people are receiving ibogaine for opioid dependence in Calgary and Canada. The problem is we don't know, and I actually did a significant amount of research trying to figure out if I could give you guys prevalence estimates for use. The problem is it's completely unregulated, and there is no central repository of any type of prescriptions or distribution. There are ibogaine centers in every major Canadian city. There's multiple in Vancouver, Toronto, Montreal, etc., and at least one in Calgary that I could find, the Inukshuk Center, which I showed in my slides. However, we have no records of how many people use them. Based on online communities, I'd say there is significant usage of ibogaine, and especially in the US, there's lots of popular media that details going to clinics in Mexico kind of as a last resort to try and deal with severe opioid addiction. So the short answer is we don't know. The long answer is I suspect there's probably a significant number, and we may start to see it more frequently in the emerge, especially in current context where we know the opioid addiction is worsening in the context of the COVID crisis. Thank you for the question. Okay, well, if there are no other questions, I think we will leave it there. Thank you everyone on behalf of myself and Ben, for tuning in this morning. And yeah, thank you so much. Oh, sorry, Ingrid just popped in with one. So just a comment about ibogaine, having done over. Okay, so the comment is having done significant numbers of intakes with opioid dependent patients seeking treatment in a specialized outpatient clinic. Only 2 patients have endorsed ibogaine use either in Mexico or in Ontario. Most patients, when asked, never heard of it. So like I say, it is difficult to know. Certainly we had seen a few cases at the Rocky View, which was what prompted this talk, but like I said, kratom is probably going to be the more prevalent drug that we're seeing in Calgary. Oh, and the cost is significant, so $10,000. Yeah, for sure. The cost is never advertised in some of the clinics that I found, but certainly in some of the Mexican clinics, they have fully paying patients who they use to subsidize patients who can't afford the full cost. Okay. All right. Thank you, everyone.